poorly controlled diabetes. There's just a whole gamut of reasons why you wouldn't be a transplant candidate. Other reasons are social reasons, financial aspects, and some of those are kind of the things that I look at. But that's when we talk about somebody being a destination therapy, is that we're willing to implant them with this type of device and give them the chance to live several more years, but knowing that they are not ultimately going to be transplanted off of their palm. Does that make sense? Okay. All right. And then is this me?
Yeah, RVAD and LVAD, do you want to say?
Yeah. So basically, given all of that information that Jim just went over, and it was just horribly depressing with the number of my, caseload, it just sounds awful. But you're probably wondering, well, geez, what the heck does Nina do? Like, what does a transplant social worker do? How can we, just sit on my butt all day, right? So anyways, Jim kind of mentioned that the primary role of a transplant social worker is, like he mentioned, when somebody is being evaluated for LVAD or transplant. The government mandates that they meet with a social worker. I don't know how many of you remember going through your transplant evaluation, your testing. You had to go through all of these medical tests, your PFTs, your vascular labs, your left heart cath, your right heart cath, your echo, to see if medically you're appropriate for transplant. Well, then somebody also has to be socially appropriate for transplant too. All of you know it takes a village to get through transplant. It is a huge process. You need the financial resources, you need the family support, all of these, you need the insurance, the ability to get through this process and then sustain your transplant for the long run. And that's our goal, is we want people to be successful with their heart transplant. So what I'll do is I'll meet with each person being evaluated or considered for LVAD or transplant, and just kind of look at all of these different areas and identify potential barriers so that we can help address those to make them a successful candidate and get them to transplant. So that's probably the primary role. Then what happens when somebody is transplanted? So let's say you either have an LVAD or you go straight to transplant, then you're back home and you're doing fine and dandy, everything's going great. Well, gee, what does Nina do? What's my role? It's kind of hard to explain, but basically I'm a one-stop shop. So I follow all of the post-heart transplant patients, and like Jim mentioned, we have about 450 post-heart transplant patients, and as you guys know, you're followed by our physicians and our nurse coordinators in our program for the rest of your life. You can be 25 years post-transplant and you are still our patient. And so that means that you are still my patient too. There is no time limit on the potential for you to call me with any issues. So many of the things that I will work with post-heart transplant patients on deal with your post-transplant immunosuppressants and your medications. How many of you know how expensive those medicines are? Yes, they are hugely expensive, and you have to take them every day for the rest of your life. You can't skip doses. You can't, go without your medicines because you'll go into rejection. You'll get really sick. So I would say that one of the main things that I do for our post-transplant patients is help them identify ways to be able to get those medicines. If there's ever a time when you are struggling with your co-payments for your medicines, or anything like that, you need to call us and let us know, because there are tons of patient assistance programs out there. So I will work with people to identify copay cards, grant monies, patient assistance programs through community resources or the pharmaceutical companies, and I can help you, guide you through that process and how to sign up and see what you're eligible for. So that is a huge thing. Other things that we typically deal with on the post-transplant side is questions about Social Security disability. A lot of people are on disability because of heart failure. You're used to working, and then you go into heart failure and you have to apply for disability benefits. So I don't know if many of you know that after you're on disability for 2 years, you become Medicare eligible. Okay? Then after transplant, what does that mean for your Medicare and your disability? Does that go away? How is that going to be impacted? These are questions that I can help answer for you, and just go ahead and call me if you're dealing with that situation, you have questions about how to navigate the system or looking long term, and we can address those too. Let's see here. Pretty much, provide community resources. That's kind of a broad area. Again, it's kind of a one-stop shop. If anybody ever has any concerns with accessing transportation to follow-up appointments, lodging, we have lots of patients who live out of the area. They live several hours from St. Louis, and if you have an early appointment and are worried about getting lodging secured for the night before, and finances are an issue, go ahead and give me a call. I've been working very closely with Vince in the apartments. There are other community resources that we can link you with, transportation resources. So really, it's just making sure that you guys are aware that, even if you're 5 years post-transplant and doing well, that doesn't mean that if you have a concern about anything under the sun or just a question that you can't call a transplant office and speak to me just to see if I might be able to help out a little bit.
I want to highlight that point. Hi, my name is Jim. I'm a grantaholic. I'm a closet grant writer in my spare time. I have a grant from your organization, but I have grants from 23 other organizations. So what Nina is saying is we are very, very fortunate that we have funds and things to help our patients that many other places do not have. So if you get nothing else out of tonight's discussion, if you have a need, please call us.
Tell them that they have to ask.
You have to ask.
That's the most important thing that you can get across here.
God bless Nina. She is the sweetest thing on earth. She will walk into your room and she will say, I'm Nina, and can I help you with anything? Do you need anything? And she is so sweet and polite. What she's not saying is, are you having financial difficulty? Are you having problems at home? Do I need to hook you up? Are you feeling low, blue? Do you have depression? Do I need to get you a therapist? On and on and on. Now, I do know she does do that too. She's just not as direct as me.
Is that permissible through you?
It is.
Oh, okay.
It is. So what I want you to leave thinking about from this portion of the talk is, we have these things, but you have to ask us. We can't read your mind. If you're struggling with something and you're home, literally, I had a need years ago to get patients from far locations, and I had no way to get them here. I am not proud. I'm a lot of things, but proud ain't one of them. I started calling airlines, and I said, I need you to give me some tickets. And I am here to tell you that you should fly Southwest Airlines because those people are phenomenal. When I called them and I started telling them the stories and what I needed, the lady said to me, let me call you right back. And literally within 30 minutes, she called me and she said, I am sending you, and I'm not allowed to tell you how many, I'm sending you X number of tickets. And every year, for 5 years, she's increased the amount of tickets. And we use them. So we have these things that a lot of folks don't have. And we want you to use them. We have criteria. I just can't walk through the room and throw the $100 bills on the table. But there are criteria. And I wish I could. But the key point I want you to have is that these resources are here. We have them. We have a lot of them. And if one doesn't work for you, another may. But you have to tell us you need something so that we can. Nina is phenomenal at sorting through all of these programs.
Yeah, so that's, I think, a big takeaway is, like I said, just because you might be 10, 20, 15 years post-transplant doesn't mean that you're not, my patient and you're not still actively followed by our transplant program. Because again, our goal as transplant providers is to make sure that you live a long and healthy life post-transplant. And any needs that come up that might interfere with the ability to be successful with your transplant, we want to know about and see if we can help address.
Excuse me,
Absolutely.
if you do all this, why is financial need one of the criteria to get the LVAD and the transplant?
Well, that's a great question. I would say that, so one of the things, I believe that Sina Winfrey came a few
Yes,
months
she
ago,
did,
talked to, but she's our financial coordinator. So she's part of our transplant team as well. And so going through that transplant process, she will look at your insurance coverage and see, what your coverage is going to be for transplant. But that doesn't come into play, you might not learn that you have a $300 copay on your Prograph, until after transplant. And even though you have good insurance, you still have a $300 copay. And even if you have a decent income coming into the house, that's hard for anybody to deal with. So that is, that's something that we can't necessarily predict. Things happen after transplant, I was kind of mentioning earlier, if anybody had been on Social Security disability because of heart failure prior to transplant, well, what happens after you're transplanted and you're doing well? Does anybody know?
Yeah, they pay for your if you were on Medicare,
Uh-huh.
they pay for your immunosuppressant drugs.
Correct. So let's say that you had disability.
Repeat that answer, so everybody hears it.
She said that, if you had Medicare at the time of transplant, then they paid for your immunosuppressants. But Medicare only covers 80% of your immunosuppressant. You have to have a secondary insurance. So we have some people who are transplanted and might not have a secondary insurance. So that 20% on that medicine can be quite costly. And just because they might not have a secondary doesn't mean that we're not going to transplant them and say, oh, sorry, you're not going to get a heart and you're not eligible for transplant.
And you're not allowed to pay for insurance because of a hospital.
Correct.
That's
Yes.
another part of the answer.
So I'll answer your question directly. She's a nice one, I'm the direct one. The federal government says I can't do it.
Yeah.
So there is a law, and the name of the law is Stark. And the Stark law says that I can't come around and put $100 bills on the table. That is incenting you. So when
Incenting for a heart
incenting, right, incenting you to use my hospital for care. So when we do this, the federal government has these rigid criteria that we know behind the scenes, and we're asking you the questions. And then myself and one of the other social work supervisors, we do all the crunching of the data in the background and put that through an organization that helps make sure that we stay on the up and up with the feds. But it's the federal law that says I can't incent you, so that's why we just can't do it. You have to meet that
It's
financial
hard to give money
criteria.
away, isn't it, Jim?
It is really hard. Again, some of these things are the things that I work hard so I fall asleep easy. I wake up at 3 in the morning, so I don't tell people what keeps me awake at night. It's like what wakes me up at 3 a.m. How do I do this? I mean, Vince and Ken and I don't know how many meetings we had talking about how do we spend this money and how do we do it in a way that's appropriate for the patients, but still meets the Stark guidelines and all that stuff. It's really sometimes a challenge.
Yeah, go ahead.
How can you incent somebody if you're the only game in town?
That's an excellent question. How can we incent somebody if we're the only transplant center?
Yeah.
I don't know the
The
answer.
incentive is if I pay you something to come to my place instead of going someplace out of town.
Well,
Because there are a lot of places that don't do.
Colorado or?
Yeah. So
Vanderbilt.
for instance,
Elizabeth and Arizona.
Arkansas has no hospital that does a bone marrow transplant. So those patients, many of them come up to us because there's no place to do it. And I mean, I can go through different diseases, different treatments where things aren't done. And honestly, I think we're looking at the wave of the future. I mean, a lot of the discussion that's gone on in our place over the last 5 years with these laws coming in is, do you provide full services in every hospital that you have? We have 12. So do we do cardiac casts in all 12? Do we strategically pick hospitals so patients don't have to travel too far. And that's my guess what will happen.
Yeah.
I can't tell you what Steve Lipstein or Rich Lightweight are thinking, but when I sit in those meetings, my 2 cents worth is we pick strategic locations where we do these things. And we pick them across the country as well. And we partner with people across the country. That's the other thing that's really different than business. I assume most of you are business people. And I was a business guy before I was a healthcare guy. And when I was in business, you did not share your secrets. You didn't tell people. You certainly didn't do what I did tonight. You never shared your numbers with anybody. And if a competitor asked you, you lied to them. Right? You always inflated, oh man, we are doing so good, we can't believe it. In the healthcare business, we have full meetings across the country where everybody comes and talks about how they did it, how they're doing it, how they're doing it better, and who's got a better idea. I mean, it's really very different thinking. So there are collaborations going on across the country trying to figure out where do you have like transplant centers. Because you don't really need a heart transplant program in 12 hospitals in the BJC chain or in all the chains are independents in St. Louis.
The last point, the facilitate the support group, that's specific to the LVAD patients. I know historically the Barnes social worker has run the heart transplant support group too. The LVAD support group is primarily for LVAD patients. It's held during the day on the first Monday of each month, and it coordinates with the LVAD clinic. So many of those patients are coming in and seeing the physician, getting their labs drawn and things like that. So I currently run that group. And the reason that that group was developed, oh gosh, about 5 years ago or so, was because many patients were verbalizing that they felt like there was a specific need to have a group of their own just with LVAD patients. I think that HTA has some current LVAD patients that attend these meetings. So yeah, I have lots of patients who come to both
and encourage them.
Absolutely.
They're perfectly welcome.
Pre-transplant patients, absolutely.
Yeah.
So I think that one of the initiatives that we're working really closely with HTA on is to get more pre-transplant patients involved with HTA and get them referred and involved earlier on in the process. So one of the things that we are doing with the transplant center is when they are going to be listing patients for heart transplant, they will actually be sending out HTA's brochure and a letter saying that this is a community support organization that may be able to provide some great resources to you throughout the transplant process. So we're really trying to get people involved with HTA and encourage them to come and get involved with this network of supports.
Have you had any post-transplant patients go to the LVAD meeting?
Yes, we have several patients who had been active in the LVAD group and then
Didn't you go?
Tom Nichols.
Yeah.
Tom Nichols.
Yeah.
Mm-hmm.
So they go.
When Larry had his LVAD, we went.
Yeah, but did you go after your transplant?
No,
Sure.
Okay.
Yeah. So we have several patients that come back, and then go,
Because
come
I
to
think it would be
HT
nice
as well.
to let them see what could happen afterwards.
Absolutely.
That's why I asked.
Yeah, absolutely. So the goal is, to try and get people involved with HTA earlier on, pre-transplant, so that they're kind of not, feeling kind of like left out.
Big happy family.
Yeah, exactly.
Not so big tonight, but yeah.
So we're happy.
Absolutely. Are there any other questions? I know it probably seems pretty broad and general, but I would just kind of like to drive home that, post-transplant, if any of you have any needs whatsoever, questions, again, disability, insurance, medications, transportation, anything under the sun, do not hesitate to give me a call.
I got a question and I'm gonna name names.
Okay?
I get my immunosuppressant from the drugstore on Euclid, Caremark something or other.
Okay.
I have the most excellent insurance.
Uh-huh.
I have Medicare, I have Federal Blue Cross Blue Shield. I pay nothing.
Mhm.
They are sending me bills for a deductible that I don't have. No, now I have to get a hold of the coordinator, because they won't send me my medicine. And I got EOB saying I owe nothing, and they're disregarding it. So do you handle that? Does
Interesting.
Cena handle it?
No, that would be me, post-transplant. Cena doesn't typically get involved post-transplant. She does all of the financial coordination of benefits pre-transplant. But if you are having a billing issue with your
And the
pharmacy,
pharmacy says, well, we called Caremark, CVS
Right.
Incorporated, and we told them your insurance, and they don't pay any attention.
right, yeah, go ahead, we
Because
can
they won't
talk,
send me my
yeah.
medicine now.
Yeah, absolutely. In a situation like that, you need to call me and we can dive into specifics, talk to the pharmacy, take a look at your insurance and see. So a lot of pharmacies, believe it or not, are not familiar with billing transplant medications. They don't understand the way that
But
it's
this
billed.
is the one that connected to the
A specialty
hospital.
pharmacy. Yeah,
I've had
give
that
me-
same problem with that same pharmacy.
yeah,
I have the same insurance you have, federal,
yeah,
PPO, and I had that same, and they were charging too much. And then when I found out that I could go and get mail order, it dropped from $700 to $80 at that same pharmacy on Euclid.
right,
I'm naming names too.
right.
And
It's not our
they
pharmacy.
are notorious. They came to my
It's a very
bedside.
complex answer.
They came to my bedside and gave me my medicine
Right,
in a bag. They came and told me, and they kept doing this, and then there was a billing issue,
yeah,
and it continued to be a billing issue for over a year,
yeah,
until we just decided just to pay them
Yeah.
to get them off our back, because they kept calling and harassing.
right.
And then we ended up, and we found out that going mail order was that way. And I was on Medicare,
Prior to transplant.
yes.